Due to the current COVID-19 pandemic, some of our usual processes may have changed. Throughout this presentation, we'll identify the changes via the coronavirus symbol.
Welcome to the Rapid Recovery Programme for Joint Replacement Surgery at Hillingdon and Mount Vernon hospitals. We were one of the first centres in the UK to introduce the Rapid Recovery Programme and have been running this successfully for the past 10 years. My name is Jay Smith. I'm one of the orthopaedic consultants here at the Trust, and I'm clinical lead for Rapid Recovery. At Joint School today, we will endeavour to give you the information required so that you can understand what is involved before, during and after your procedure. Listen carefully to the talks that you will receive today, and if anything is unclear, please do ask questions. Key points to take home is that your hospital stay will be short. Expect to stay 2 to 3 days following your procedure. Joint replacements will continue to improve for up to 12 months after surgery, but you should feel benefit from this much sooner. You will now receive talks from members of our staff, including anaesthetists, physiotherapists, occupational therapists and nursing staff who will be involved in your care whilst you're here at the hospital.
Hello, my name is Valerie. I'm a nurse from pre-op. I just want to remind you that if you have any insect bites or any sores or any wound in your legs, so you let us know before you're coming in for the surgery. It's just to avoid the surgery to be cancelled. If you're unwell, have any infections, please do let us know.
You will receive a COVID-19 swab 72 hours prior to your admission. You will be informed of the time and day to attend over a telephone call. This is operated as a drive-through near the treatment centre at Mount Vernon by the bike racks.
So good morning, my name is Josie and I'm one of the sisters that work at Trinity Ward at Mount Vernon. Your operation is likely to take place at the Specialist Elective Orthopaedic Department at Mount Vernon Hospital. The doors to this building do not open until 7:30 a.m.
We are currently asking all patients to enter via the minor injuries entrance so you can receive a temperature check on entry.
If you have your operation at Hillingdon Hospital, you should report to the daycare unit. It is likely that you may also be transferred to Mount Vernon Hospital during your stay. On the day of your operation, when you arrive, you will be shown to your bed and be seen by the nurse, anaesthetist and surgeon to fill in some paperwork and consent to the procedure. We cannot guarantee what time your operation will be as the surgeon's list can change on the day. Post-op day 1, which is the day after your surgery, drips and drains will be removed. You will have an x-ray of your joint. Please dress in your own day clothes. You will be regularly monitored. Nursing staff will ask you your pain levels and check your blood pressure. Do not start to walk, mobilise, unless the physiotherapist has said you can do so independently. Don't be afraid to ask for help. During your stay, you will have an anticoagulant injection every day whilst in hospital. You will be prescribed laxatives. These are important as not going to the toilet can make you feel unwell and may delay your discharge. On discharge, you will be given aspirin 150 milligrams daily to help prevent blood clots. During your stay, visiting hours are 2 p.m. to 5 p.m. and 6:30 to 8 p.m. every day. Please act responsibly and ensure that you have strictly only 2 visitors per patient. For the benefit of others, all mobile phones must be switched off by 10 p.m. at the latest. Discharge planning. It's expected that you will go home day 2, day 3 after your operation. Transport where possible. Please arrange your own transport home. We aim to discharge you by 2 p.m. You will receive a check-up phone call when you are at home. Wound care. Although it is common to get some swelling and redness following your procedure, if it becomes excessively red, swollen or starts weeping, you should contact the ward sister. Your wound should be kept clean and dry. This will be reviewed before you go home. Removal of staples or wound check will take place at 12 to 14 days by your practice or district nurse. The key points are: doors open at 7:30. Please bring your day clothes. We encourage you to mobilise, but do ask for help if you need it, and don't walk until we have said you are safe to do it. Organise someone to pick you up day 2, 3 by 2 p.m.
Hi, my name's Ishani, I'm the pharmacist. I'm going to be going through what medications you can expect to take before, during and after your operation. So we need to know what medication you regularly take. This not only includes any tablets prescribed by your GP, but any creams, eye drops, ear drops, patches, injections, anything like that prescribed by your GP, as well as anything you buy over the counter, whether that's at your pharmacy or your local supermarket, any herbal medications and any supplements that you take. At your pre-op assessment, please inform us of all the medication that you're taking, as well as any allergies you have. We can then advise you if any of your medication needs to be stopped prior to your surgery and for how long. Some medications that are regularly changed prior to surgery are blood thinning medications such as aspirin and warfarin, any medication for diabetes, water tablets or diuretics, hormonal tablets, and some blood pressure medications. If you're unsure of what medication needs to be stopped, then please ask us. Please make sure you bring in all your regular medication in their original labelled containers and bring enough for the duration of your inpatient stay. So I'd say around 7 days worth. And make sure you have enough of your medication at home for when you're discharged. We will supply you with any newly prescribed medications on discharge. During your admission, you can expect to take your regular medication if they're still appropriate. So for example, if you're taking blood pressure medication and your blood pressure is low, we might withhold some of these doses. You'll also be given some blood thinning injections. This is to prevent any clots forming now that you've had your surgery. You'll be given IV antibiotics to prevent any infections occurring during your surgery. And if you do develop infection after your surgery, you'll be given antibiotics to treat that as well. You'll be given regular painkillers as well as some regular laxatives. Your painkillers will be slowly reduced down depending on your level of pain. So for discharge, we will give you some oral blood thinning tablets. Usually this is aspirin. You can expect to take them for 10 days if you've had a knee replacement and 28 days if you've had a hip replacement. Some painkillers you'll need to take regularly and some of them just as and when you need them. And as well as this, we'll give you laxatives to take just when you need them. Okay, just to sum up, please make sure you bring in all your regular medication in their original containers and follow the advice from your pre-op assessment with regards to what medication may need to be withheld prior to your operation. And if you do have any questions, please feel free to ask us.
Good morning, my name is Dr. Michelle Stevens. I'm one of the consultant anaesthetists here at Hillingdon and Mount Vernon, and I'm going to give a talk to you today about the choice of anaesthetic for your hip or knee replacement surgery. Anaesthetists are the doctors who deliver your anaesthetic, and your own anaesthetist will come and see you on the morning of surgery. So there are different types of anaesthetic. The main two choices are general anaesthetic or a spinal anaesthetic. Spinal anaesthetics are what we tend to do more commonly, but I will go through both. Whichever type of anaesthetic you're having, there are some simple rules. Nothing to eat or drink for 6 hours before your operation, and nothing to drink for up to 2 hours before your operation. You can carry on drinking clear fluids, water, black tea or black coffee up until 2 hours before. When you come into the hospital, do ask the staff if it's okay to have a drink on the morning, because there might be some delay until you actually come to theatre. So a general anaesthetic is an anaesthetic that puts you off to sleep. It makes you unconscious, so you'll be unaware of what's going on and you won't feel anything. It doesn't provide pain relief, so on top of the general anaesthetic, we also need to give you strong pain-relieving medications, and it's those medications that do tend to make people feel a bit unwell and a bit sick after their surgery. You can also get a bit of a sore throat with an anaesthetic because of the gases, which are a bit drying, but again, we can give you pain relief to manage that. A spinal anaesthetic is an injection into the lower part of your back, and it makes you numb from the waist downwards. That numbness lasts 2 to 3 hours. You'll feel no pain, but it doesn't put you to sleep. If you don't want to be awake, then we can give you some sedation so that you snooze your way through the operation, which we switch off at the end. You wake up very clear-headed, generally with the spinal still working. The advantages of a spinal anaesthetic over the general are several. One, it reduces the blood clots to legs and lungs, which you are at risk of because of the type of surgery you're having. There's less bleeding during the surgery, so less need for blood transfusions. You do remain in control of your breathing, so if you do have respiratory problems, it's a particularly good anaesthetic for you. We don't need to give you those very strong pain-relieving medications that do make you feel quite sick. So there's less sickness, less drowsiness, and you'll be able to eat and drink as soon as you get back to the ward. One of the other big advantages of having a spinal is that you can leave your dentures in. The disadvantages of spinal anaesthetic is that you can't move your legs for 2 or 3 hours, but you're not going anywhere, so that's not a problem. You're not always aware of needing to pass water afterwards until the spinal's worn off. You might find you get a little bit itchy around the face and the chest. There is a small chance of a headache which we can manage, and very uncommonly there can be some damage to nerves, but that's generally temporary. So in summary, you've got a choice of a general anaesthetic or a spinal anaesthetic. We do take into account your preferences. We do encourage people to have a spinal anaesthetic because we feel that for the enhanced recovery programme, it is the best anaesthetic to have. Nothing's going to happen without discussion, and when your anaesthetist sees you in the morning, they will go through any of your concerns. So if you do have any questions that you think of, just write them down and you can ask your anaesthetist on the day. Following the surgery, we're going to need to manage your pain because, unfortunately, this surgery isn't painless. However, we do manage your pain with various methods and we assess your pain. So we will be asking you what your pain score is. Now we score your pain either using numerical score of 1 to 10, with 1 being the least pain and 10 being the worst pain, or just from a description of it being no pain or mild to moderate to severe pain. It's important to know what your pain score is when you're at rest, as well as on movement. In order to manage your pain, we use a variety of painkillers, from paracetamol through to non-steroidal anti-inflammatories if you're okay to take them, and also the stronger opiate painkillers. We use them generally as tablets or liquids. We may use suppositories. In addition to the medicines, also some simple techniques such as positioning and so keeping your leg elevated while you're at rest, using ice, both of which will help to reduce the swelling, and distraction, so bring books, knitting, crosswords to keep yourself busy rather than just focusing on the pain. All medicines have side effects, and the stronger painkillers, as I've mentioned before, do have side effects, including nausea and vomiting. Constipation is a bit of a problem, so we do start you on some medicines to help with constipation, but do make sure you're using a good diet before you come in. You might find you get a bit itchy and a bit dizzy, a bit drowsy. All of these things we will manage, but you just need to tell us. So if you're not feeling quite right, just let us know and we will possibly change that medication to help. So main key points for your surgery: make sure you have carried on drinking until 6:30 in the morning. A spinal anaesthetic is a very good choice of anaesthetic for this surgery. It does reduce the overall amount of pain relief that you need afterwards. You're also able to drink and eat straight away, and we are going to get you up and about nice and quickly after your surgery.
Hello, my name's Charlotte. I'm one of the physios on the ward. I'm here to just talk to you today about what to expect in terms of your recovery and physio after having a hip or a knee replacement. So as a therapist, it's my role to get you up and get you moving as soon as possible. That may be to have a look at your walking and to have a look at the exercises. However, in terms of the exercises, it is your responsibility to make sure that you're doing those, okay? The sooner you get up and doing those exercises and the more often you do them, the better your recovery will be after your surgery. Now, most people expect to be better and fully recovered after surgery within 2 months. Unfortunately, that's not quite the case. It will take somewhere between 6 to 12 months until you are fully recovered after your surgery. Everyone always asks us about how long they're going to be in hospital for. If you are having a total hip or a total knee replacement, you can expect to be in hospital for somewhere around 2 to 3 days, whereas if you're having a partial knee replacement, you can expect to be in hospital for 1 to 2 days. If you're in over a weekend, you will still be seen and can still be discharged over the weekend. The day 0 is considered the day of your surgery, and sometimes we will be around to see you on that day. Okay, so 4 hours after coming off the operating table, we will be around to get you up and walking. So that will be with a nice supportive frame, and that will be with one of the physios. If it's not with a physio, it may well be with one of the nursing team, and they'll be there to help transfer you out onto a commode or potentially the toilet rather than using bedpans. You can begin your exercises the day of surgery, so please make sure that you do so. Day 1 is the day after your surgery, and the nurses will be looking at getting you out and sat in the chair so you can eat your breakfast and your meals out in the chair. You should be doing your bed exercises again and the chair exercises. You'll be getting yourself washed and dressed into your normal day clothes, and we can look at progressing that walking with a Zimmer frame. Please make sure that the first time that you're getting up and walking, you don't do so on your own. You wait until you've got one of the nursing staff or the physio staff there with you, only because after having the anaesthetic and all the painkillers that they give you, there's potential for your blood pressure to drop and you to feel a little dizzy, and we just want to keep you as safe as possible. On days 1 to day 2, depending on how you're getting on with your walking, we can look at progressing you from the frame to either sticks or crutches, and we can progress your exercises as necessary. And then again, depending on how your walking is getting on, anywhere between days 1 to days 3, we can look at doing some stairs with you. Once you're independent with your walking and you're independent on the stairs, we can look at sending you home. For those of you having a knee replacement, there is a minimum requirement of knee bend, and that is 70 degrees. You have to achieve that before you can go home. And then when you come back for some outpatients physiotherapy, we'll be looking at you getting a minimum of 90 degrees, which is considered to be functional for a knee. For those people that decide not to do their exercises, there are some nasty complications, unfortunately. What can happen is your knee will get really, really stiff if you don't do those exercises. That can therefore contribute to more pain and reduce your ability to walk. So please make sure you keep the knee moving. It's really, really important. There are a small percentage of people every year that need to come back into hospital to have what's called a manipulation under anaesthetic, which means you'll be put under anaesthetic and they will force you to bend your knee, unfortunately. So the key points to take from this talk is to make sure that you're exercising and walking at least every hour, a little and often. Don't try and overexert yourself. You're taking painkillers regularly to help with the pain, and you can put some ice on your knee to help with the swelling. Please make sure when you're putting ice on, you're putting it in a bag, wrapping it up in a tea towel or a pillowcase, and no longer than 20 minutes at a time on the knee.
You will be informed of the process to remove your clips and stitches before you leave the hospital. Physiotherapy follow-up will be done by a virtual appointment, which you will be given the details to before you leave the hospital. If you may struggle with a virtual appointment, the therapy team will discuss other options with you before you leave. If you have had a knee replacement, you will receive this appointment approximately 10 days after your discharge from hospital. If you've had a hip replacement, you'll receive this appointment approximately 6 weeks after discharge from hospital. Finally, you'll be reviewed in the joint arthroplasty clinic at 6 months following your procedure.
There are some feedback forms for you to fill in if you feel like you'd like to. So I'm just going to go over some of the exercises that are all in your joint school booklet, so we want you to be doing these regularly, as I said. The first exercise is some ankle pumps, so you're just moving the ankle up and down as demonstrated by Lauren. This is a really important exercise for your circulation and to get all your kind of blood pumping and things like that, but it's not going to help your hip or your knee replacement to recover. So please make sure you're doing the others as well, because I often find that this is the only exercise patients tell me they're doing. The next exercise is just trying to get your hip and your knee bending. So you're going to slide your heel along the bed as far as you can, pushing into a little bit of uncomfort as you feel you can tolerate, and then sliding back down nice and gently. The next exercise, more predominantly for knee replacements, is just going to work on the quadricep muscles there. You're going to push the back of the knee down into the bed. You can see here Lauren's heel just raises from the edge of the bed there, really tightening up on those thigh muscles. Try and hold that for 5 seconds if you can, and then gently relax. I'm going to lay the bed down for Lauren now. And the next exercise is looking at some
Glute bridges. So what we're going to do is we're going to bend both of your knees up. You're going to clench your bottom muscles together and try and lift your hips up nice and high from the bed. Again, holding at the top if you can for 5 seconds and then gently relaxing back down. This is an exercise designed for those having hip replacements predominantly. The next exercise, if Lauren, you straighten out your legs for me. Again, for hips, you're going to slide your operated leg out to the side and then again gently sliding back in. Try and keep your knee as straight as you can as you do that and your toes pointing up. This exercise can be done in lying or in standing. If you're doing it in standing, holding on to something, so the back of a chair, a bed, your kitchen worktops, and again, nice straight leg, and you're taking that out to the side and back in. Try not to let your trunk lean. That exercise can also be done backwards. So again, still holding on, keeping the knee nice and straight, and you're taking your heel behind you. Lauren, I'm just going to sit you back up again. So the next exercise, with your unoperated knee bent and your foot on the bed, you're going to grab a pillow or a towel rolled up and popping it underneath your knee. Okay, then you're going to bring your toes towards you and lifting your heel up off the bed. Again, trying to tighten up these thigh muscles, holding at the top there for 5 seconds and gently relaxing back down. Lauren, I'm going to ask you just to sit on the edge of the bed for us now. And I'm going to bring you down a touch. And what we're going to look at is just bending your knee there. So what I want you to do is just slide your heel back as far as you can. So you're trying to get that knee bending as much as you can. Again, working into a little bit of uncomfort as tolerated to try and really achieve that 70-degree knee bend. Also, while you're sat in the chair, you can look at doing some strengthening exercises. So straightening up your knee in front of you. Again, tensing up those thigh muscles, holding at the top for 5 seconds and relaxing back down. With all of these exercises, we want you to try and do 10 repetitions of each. So you're trying to really work on the muscle strength and the range of movement in your knee. And we want you to be doing them hourly as possible.
Hello, my name's Helen. I'm an occupational therapist. I work on Trinity Ward at Mount Vernon Hospital. Welcome to Joint School. You're probably all here because you're experiencing pain, difficulties with stiffness and difficulties with function. We're going to talk about the hip and knee today. We'll go through a bit of hip anatomy. As you can see from the picture, we've got your normal hip joint on the left, and on the right we have an arthritic hip. What happens is that the cartilage wears and you get bone rubbing on the bone, so that's why you get a lot of pain. What will happen when you have your surgery, they will replace the femoral head and socket with a new joint, and they will also replace the cup in the acetabulum, which is in the pelvis, and there will also be another cup made of surgical plastic which will act as a buffer between the two joints. This is as you can see, this is a healthy knee on the left, and on the right we have an arthritic knee. You get cartilage wearing down, and then you get bone rubbing on bone, and you get the excruciating pain. On the left we have a total knee replacement. The surgeon will put one prosthesis into the femur bone, which is the thigh bone, and the other part of the prosthesis will go into the tibia, which is a weight-bearing bone. In between they will put some surgical plastic which acts as the cartilage. On the left you have a uni knee, which is a half a knee, and this is a quicker turnaround. You will be out in 2 days after having this surgery as opposed to 3. Just a reminder of what to bring into the hospital with you. If you can bring your day clothes, your Joint School booklet that you've been given today, if you can bring your shoes, your toiletries. There are towels available, but you can bring your own. We do have free Wi-Fi on the ward, but if you want to bring your laptops and phones and chargers, you are welcome. But please be aware that there are other people on the ward in the bay with you, so obviously think about noise. If you want to listen to music, if you can bring your headphones with you. Obviously, we are concerned about you having falls. You will go home with walking aids, either crutches or sticks. So if you can ensure you do a risk assessment before you come into hospital, think about pathways, clearing any rubbish inside. If you can think about any clutter, any loose rugs, anything that you might fall over. Think about your lighting. A lot of people fall because they've got dim light bulbs. Just make sure that you check all those. Obviously, with the hip and the knee, you may have difficulties bending down in low cupboards, so move everything up. Particularly people who live on their own, if you can freeze milk, bread, things like that, just in case you can't get out to the shops. Think about a light by your bed, so when you get up to go to the toilet, that you don't trip over. So put your light on and then you can look for your walking aids. And particularly people who live on their own, think about leaving a key with somebody just in case we need to deliver equipment. Footwear, very important that you've got sensible shoes. Your feet will swell up. So if your shoes are tight now, please don't use those shoes. Just make sure you use shoes that have got Velcro or elastic. Please no lace-up shoes or flip-flops or high heels or any slippers without backs. So just be mindful of the shoes that you bring into the ward. You will be up on either the day of your surgery, but the next day you will be expected to be up after breakfast with the physios and be dressed. So think about loose-fitting clothes, something with elasticated middle, large t-shirt, so that you're comfortable and ready to go for the day. We're very up on health promotion at Mount Vernon Hospital, so you can think about your diet and perhaps losing some weight before you come in. There will be less weight on the joint, and obviously that will mean you'll have a better recovery. Think about your fruit and vegetables that you eat daily. It's recommended that you have at least 5 portions a day. And think about your calorie intake from fatty foods and sugar, and make sure you cut that down. If anyone's got friends and family with them today, or family with them at home, or a friend, just encourage them to motivate you to do your exercises. If you can get them to encourage you to take your pain medication, and also have them on hand to be able to help you with housework, shopping and things like that. But obviously the exercises, it's your responsibility to do those, and the people that do the most exercises will have the best outcome. My role as an occupational therapist is to help you maintain your independence. I can teach you techniques to wash and dress on the ward. We can look at equipment for your home to raise up your toilet and your furniture, and we can also encourage you to return to work and any other activities that you might do in your daily life. With regards to washing, we advise that you don't sit in the bottom of the bath for at least 6 weeks. We do have equipment that can help you get in and out of the bath. And we also have equipment that you can buy afterwards, like long-handled shoe horns, grabber sticks and leg lifters that can help you. Also bear in mind it will be difficult to bend down to your feet, so think about your foot care before you come into the ward. Obviously when you dress, think about your furniture you're sitting on. Don't sit on anything low, like the bed or the chair, because you may find it difficult to get up. Always dress the operated leg first. Think about loose-fitting clothes that are easier to put on and off. And as I said before, think about your long-handled equipment that may help you with the dressing. Sleeping, there's no hip precautions anymore. You can sleep on your back, you can sleep on your side, any position that's comfortable. Some people might want to sometimes they put a cushion between their legs, but you know, whatever way you want to sleep is fine. Bear in mind that if you live alone, you might want to change the bed before you come in, because you may find it difficult to do that when you come after surgery. Driving, we recommend that you don't drive for 4 to 6 weeks. Also check that you're covered by your insurance company. Make sure you speak to your consultant if you're flying before 6 weeks, because you are at risk of deep vein thrombosis. Normally we say 6 weeks you shouldn't fly. Getting in and out of a car, if you park on a level surface, Don't park on a drop down curb because you will find that more difficult to get in and out. If you get your driver to park up, pull the seat back for you and recline the back of the seat, then you go in backwards, put your bottom in and then put your operated leg out in front. Then you swing your legs in, keeping your thighs in contact with the seat. It's quite useful to put a plastic bag on the seat because that can help with the friction and make it easy to turn. Obviously getting out, you'll have the bag under you and then you reverse the process. So basically the key points for today, we want you to prepare your home for discharge, make sure there isn't any trip hazards, think about your day clothes. We want you to be as independent as you can before you leave hospital, and we want you to be ready for home on day 2 or day 3.
Hello, my name's John and I'd like to talk to you about my experience that I had when I had a knee replacement done at the Mount Vernon Treatment Centre. I'm very fortunate because I actually do work here, so knowing most of the surgeons and the anaesthetists, it was the best choice to have a spinal anaesthetic. I came in the morning, the anaesthetist came to see me and then I went down to theatres early afternoon. I was a bit reluctant to have a spinal anaesthetic, but it was the best thing that I ever decided on having done. I came, I had a simple injection into my back, went into theatre and had the operation, and then afterwards went to recovery, then went back to the ward where I was eating and drinking, because if you've had a general anaesthetic you feel sick, and having the spinal anaesthetic enabled me to actually start doing my exercises once I was laying in the bed by just bending my knee. What I will say is that the mechanics, the orthopaedic surgeons, have done their bit, and it's up to each individual to get crack on with their exercises. The pain relief was absolutely fantastic. I was written up for all my post-operative pain relief, and after doing my exercises, if I needed any more pain relief, I could request some more. The rapid recovery program to me enabled me to go home within 2-3 days, walking up and down stairs, exercising, went to physio once a week, and within 6 weeks I was not up and running, but I was up and about, and I can't emphasise enough that you need to do your exercises. Thank you.